And on the webinar, Kim, can you give us a count? Oh, great. Okay. So Amanda's with HSCRC and Sandra is with the HMH. So we have 2 people on, and then we have a number of people in the room. So Lenny, shall we start with introductions?
Yes.
Thank you.
Have to push that little green button. So this is Lenny Preston, chair of the Maryland Women's Coalition for Healthcare Reform and also of this task force. So if we could just go around and introduce, that'd be great.
Sure. This is Diane Feeney, and I'm with the Health Services Cost Review Commission.
Steve Forts with the HSCRC.
Thank you. Renee Dane with the Coordinating Center.
Gary Logan, the technically challenged one of the group. I can't my sword.
Gary's with Holy Cross.
There we go.
Becky Jones. I'm here representing Dr. Andrea Mathias from the Worcester County Health Department.
Mary Joseph with the Primary Care Coalition of Montgomery County.
Novella Tassel with Keswick. Barbara Brookmeyer, Frederick County Health Department.
Donna Jacobs, University of Maryland Medical System.
Suzanne Schlattman with the Healthcare for All Coalition.
Teresa Lee, Maryland Healthcare Commission.
Tiffany Tate with HSCRC.
Great, thank you all. So thank you for coming today. We've got just a couple of more meetings before we need to get our preliminary report into HSCRC at the beginning of July, so we're not panicking yet, but we've got lots of work yet to do. So for today, we want to review the patient engagement resources and the work that the subgroup has been doing. They've been extremely active and had some very interesting presentations at our last meeting, and I think we're making significant progress on our second charge, and I think Teresa's review with her staff of the hospital websites, honing in on the 3 areas of patient rights, consumer feedback loops, and the PFACs, I think has really helped to kind of get us focused in a positive way. And we'll look at the continuing learnings that are going on around consumer engagement initiatives, and excited to have some presenters here today on that. And then look at our communications strategy chart, and I'm hoping Hillary Zumba comes because she sent me something in the middle of the night that I think is going to move us along. So we first need to look at the minutes from the April 10 meeting. I don't know if everybody had a chance to look at those, if there were any issues with those. Everybody happy? No corrections? That's good. Love that. So let's then just roll right into the presentations. Is Shannon Hines on the phone yet? Do we know? Okay, okay. So what we want to do is take a look at some examples of patient engagement that are working and look at some of the lessons learned from those. So if we could, Becky, start with you. Becky Jones was very kind to step in yesterday, I think maybe, right? For Dr. Mathias, the Deputy Director at the Worcester County Health Department. And Becky is the Nurse Program Manager of Adult Services for the Health Department. Have I got that right? Yeah. Good. Okay. So, Becky, if we could go ahead with you, and I guess you need this. Thank you. Oh, great. There we go. Oh. And I know how you want them. They must have known. Okay. Okay.
Good morning, everyone. I am, in fact, not Dr. Andrea Mathias, although I would like to play her on TV. So thank you very much for having us here, the Worcester County Health Department. So I'm going to talk a little bit about our specific initiative in the Lower Eastern Shore, the Tri-County Diabetes Project, in which we looked at reducing the number of emergency department visits for the primary, secondary diagnosis of diabetes. I'm going to go over just really quickly, because I only have 15 minutes, so cut me off, the reasons why we developed this program, and then I'm going to go into the specifics, kind of the nitty-gritty, and focusing in on the patient engagement. So I think everybody can see the PowerPoint, plus there's copies. So for us, using the public health, our workforce, we have a history of working with our hospitals, and we're going to talk about that a little bit later, in a variety of programs. The collaboration is there specifically with Atlantic General Hospital, who is the primary hospital in Worcester County, as well as we have extensive history with Peninsula Regional Medical Center, which is based in Wicomico, and McCready, which is in Somerset County. So we're working with them to meet their goals and requirements of the patient-centered medical home model, which I think everyone is familiar with. Again, working with them to reduce overutilization for the emergency department, and then the subsequent readmissions. And of course, you know, our overall goal is improving the population health, not only of our county, but of our neighboring counties as well. As I spoke to just a minute ago, we have a significant history with our hospitals. More recently, in 2012, Atlantic General was awarded a CMS Innovation Grant. It was a 3-year grant, which is coming to an end next month. And they were looking at specific drivers for ED utilization, COPD, CHF, and diabetes. With that award, they subcontracted out to us, the Worcester County Health Department, in a partnership for one of our nurses, registered nurse, and that was a full-time position, as well as a half-time of our social work, one of our social workers, in which we were actually in their building, in their patient-centered medical home. They had about 5 care coordinators, which worked as a telephone-based care coordination, which works very well, but it doesn't work 100%. So for us, they subcontracted our services to make those home visits. For those clients that either the physician has identified that they're not engaging in the disease management for whatever reason, or there were other flags or indicators that they felt warranted a home visit, that, you know, the phone base just wasn't getting the outcomes that they wanted. So that partnership has gone very well. Although the funding through CMS is ending, we are meeting with the executives of Atlantic General to continue that collaboration, and that remains to be seen how that's going to look, but they are pleased, so we are looking forward to moving forward. In 2013, as part of our Local Health Improvement Coalition, AGH, PRNC, and McCready, we were awarded, Worcester County Health Department, a 1-year grant looking at the SHIP measures as well as the HSCRC data for, again, the utilization of the emergency departments for primary, secondary diagnosis of diabetes, and looking how we can sort of move that needle to where folks aren't using the ED for that primary source of care, getting them re-engaged back with their primary care physicians, getting them engaged in chronic disease self-management, and having overall improved quality of life. So real quickly, just about the LHIC project, the Tri-County Diabetes, again, to reduce the diabetes-related ED visits and to reduce the racial disparity in ED visit rates. And as you can see, and I think some of you have seen this data before, our 3 lower counties were not looking very well regarding diabetes and ED utilization. So we engaged with our 3 hospitals, 1 in each county. MOUs were signed, the business agreements were signed. And so initially what they would do is they would run a report from their ED, and they would identify who were their top utilizers for the emergency department. And we define this in the grant application as anyone that was having 3 or more ED visits in a year with a primary or secondary diagnosis of diabetes. The hospitals would give us that information, and then our teams, which I'll go in a little bit further later, would call the clients that were identified as high utilizers and try to engage them in a home visit and then subsequent, re-engagement in their primary care and their specialists if they weren't seeing them in a chronic disease care management, case management. Chronic disease management or case management is not new for us. We do this across the board, whether it's for our mental health and our targeted case management. HIV we've been doing for years. We've taken that model with the registered nurse and the social worker and implemented it in other areas in our health department. DD, our cancer, our high-risk OB, we do this across the board. So we took that and developed our Tri-County Diabetes Project, in which, again, we had 2 teams in 3 counties. Each team had one full-time registered nurse and a half-time social worker. One team was focused in on Wycomico County just because of the sheer volume and the population, and then the other team was split in between Worcester and Somerset counties. So our standard community-based intervention, we identified for their primary care status. Even if they had insurance and they have the name Dr. Smith on their card, we all know that just because you have the name on the card doesn't mean that you have seen the physician. You may not have seen that physician in well over a year, and the only reason why you went in there was because you had a GI bug or you had the flu. It wasn't ongoing, regular primary care. So we identified that. Not only do they have one, but are you seeing them? And certainly working with them to re-engage. Even if that included transportation. Has anybody been to our area down to the Larry Center? Okay. It's rural. I don't know if anybody's here from Allegheny, but we're kind of with you there. It's not like the city. It's not like you can hop a metro. It's not like you can wave down a taxi. It's not like you have transportation at every corner. It's very rural. And the transportation that we do have, although it's wonderful, it's limited. So it's almost an all-day commitment if you're going to go to the doctor, because you can get picked up at 8 o'clock in the morning from your bus stop, wherever that is, and you may not get home till 3 o'clock in the afternoon. This may not be new for a lot of folks, so I'm sorry if you're hearing it again. But that's something that we live with every day, and it is a barrier, especially if you have a chronic disease, if you're not feeling well. To sit on a bus for several hours for multiple stops, sit in the doctor's office, and then wait to be picked back up again is definitely a barrier to care. So transportation, we would transport the client. We did have in this original model a community health worker. I think everybody's familiar with that terminology. And unfortunately, that just did not come to pass in between hiring through the state system, which can sometimes be fun, and then just the overall budget, we couldn't handle that. So either our nurse and or our social worker would transport the patient as needed. A big thing, and what Dr. Mathias has termed the SWICU, which is the social work ICU. So many of our folks not only have somatic needs, certainly that's why they're here, they're not able to manage their diabetes, but there's also a whole host of social needs that are going on that needs to be identified, to linking them into whatever services are out there that can help them financially. So our evaluation of this, we kind of took a variety of tools. Is anybody familiar with the AIRS program through the state? Okay. A modified STEPS, and what the new term, NRI. It's just a very comprehensive evaluation of the client, not only looking at their ADLs, but also, again, what's happening in their, what we call SWICU. If they did not have insurance, we did refer to our connector entity, which again, the Worcester County Health Department was the recipient of that original grant, so it's in-house and very easy to make that referral. Med reconciliation is huge. I don't know how many nurses and or physicians that are in the audience here, but we all know that is just one on the top of the list. Because folks can bring you the baggie, and in that baggie is like 30 different pill bottles that they've gotten from multiple ED visits, and they may have been discontinued when they left the ED, but they didn't realize that, or maybe they got a generic of a medication, so they have now 3 bottles of the same medication, and they really don't know what they're taking when they're supposed to taking it. So med reconciliation is huge for our population. We certainly utilize CRISP. I think everybody knows what CRISP is in that process to see what they're filling, where they're filling it, when they're filling it. We have our team has constant communication with the pharmacy as well as their primary care once that's established and identified. The chronic disease teaching, it doesn't necessarily have to be in a structured brick and mortar referral to a hospital type of program. A lot of our clients, that's just not going to work for them for multiple reasons. So our staff had training on chronic disease, specifically diabetes education. So they had to meet the client where they are. Where are they ready? And if they made the suggestion that, hey, you know, chronic disease self-management program would be good for you, and they're like, I know that, but I cannot do that, then our staff would then do the teaching in the home. Is it, you know, the Stanford model and the however many weeks? Not necessarily. It's modified, but again, you're meeting the client where they are. It's definitely, this program is patient-centered. Identifying, you know, where they are at that point in time. And I think that from the beginning is essential. Just looking at Maslow's hierarchy, you know, if our team walks in and we're there because they've been going into the ED so many times, so we're there focused to, you know, help them through their diabetes self-management, and you walk in the house and the lights aren't on. Well, no wonder, you know, they're having difficulty managing their chronic disease because they have a $5,000 electric bill. And some eyebrows may go up on that, but that is not unusual for, you know, our populations to have enormous bills. Yeah. Oh my gosh, okay, sorry. I gotta, okay. So engagement strategies. I think our team's persistent involvement, you get what you pay for. And for us, we have experienced team, not only our registered nurse as well as our social workers. And that equals a trusted resource. When you have experience, when they do wonderful assessments, they know the resources in the community and they can connect them. Again, the person-centered approach, that motivational interviewing is essential. Supporting the compliance and self-management, seeing where the client is at that point in time, supporting that, and supporting them all the way through the process. We do not disenroll folks from our program. We continually build. The only way that they are no longer engaged with us is if they've passed on, if they have moved out of our jurisdiction. Other than that, once you're enrolled, you're enrolled. So getting them what they need, whether it be the glucose logs, the pill boxes, calendars, etc. I talked about the transportation. We provide that if that is an identified need and barrier. And then modeling provider communication. By that, we empower the client that if we're not with you at that doctor's office, you need to be your own advocate. You go in with a list of what you want to discuss with your physician, because just like myself, they have very time limited, 15 minutes. So you got to say what you got to say, get what you need, and then move on. This is just a quick model of the project, and if anybody wants to talk about that later, I'll be glad to. This is just a little bit about the evaluation in the 12 months prior to us receiving, and this just gives you some demographics or some data on our demographics. These are some of our implementation activities. Again, I talked about the MOUs and the business agreements. We were receiving the quarterly ED data, which I talked about. The universal referral, that is just a two-page form that is given to all the primary care doctors within the Tri-County area. So again, if they identify someone who's not compliant, they can check that off and they can send it in to our Maryland Access Point, our MAP. We are the only MAP in the state of Maryland which is run by the Worcester County Health Department. It's centralized, one-stop shop for any adult who is in need of long-term services and supports. It was already established. We thought that was a great way to get the referrals in and get them out where they need to go. I think about Chris. I talked about the diabetes education and the coordination. Outcomes, we had pretty good outcomes. The 59 that were enrolled as of January and September, we did a 2-year look back on those folks, and as you can see, we had an 85% ER reduction in those folks. And of the highest utilizers, we saw an 89% reduction. We now have 92 clients enrolled in the program. Can I wrap it up?
Wrap you up and move on, and then if there are questions, then come back because we've got great information here. Sorry. I know, that's okay. That's okay. It's just my job is to carry the whip.
Yes. Okay. Thank you. Sorry, I was wrong.
So, who gets this? Yes. Let's see who. Is Shannon on the phone? Okay.
Yes, I'm here. I apologize that I was a little late because I called the number that was on the agenda, so I apologize if you all skipped over me with the first presentation, but I am here.
Okay, Shannon, we're going to go ahead with Mary Jane Joseph next with the Primary Care Coalition because her PowerPoint's the next one up.
Okay, no problem.
And then we'll get to you. Thank you.
Okay. Mm-hmm.
Good morning. Thank you for having us. I'm with the Primary Care Coalition of Montgomery County, Maryland. We do not provide any direct services to patients, but we do work with many people in the county who do provide this care. Our vision is to have a community in which all the residents have an opportunity to live healthy lives. That can be a bit daunting, and our mission is to coordinate the community-based healthcare system that strives for universal access and equity for all low-income and uninsured people. Our core competencies in the primary care are collaboration, integration, and process improvement. And I bring these up because you'll see this is how we develop the health partners or help to develop it a long time ago. But we try to foster and coordinate high-quality, efficient, community-based healthcare systems. Like I said, we strive for universal access. We create models to providing access to high-quality care, and we administer some private and public funding partnerships. So health partners, what we started was in around 2011, we started work with the Montgomery County DHHS, Holy Cross Hospital, and the Housing Opportunities Commission. We were looking to see how we could improve these transitions of care for the dual eligibles. It was really beginning to say, we don't want them coming back into the hospital. What can we do? Can we do a care management model? And although we worked on this and worked hard, it really didn't go anywhere, but we kept the idea alive. And in 2013, we joined back together. We formed a coalition. Delmarva was our QIO then. They brought us together as a coalition. So although it wasn't binding, we signed a piece of paper, which meant we're interested and we're going to keep it up. So we expanded to 16 organizations. But most important, we have residents. So we had the people who were going to be impacted, and they have been tremendous throughout this whole process, who are involved. During this time, we were able to get access to Medicare data on the admissions and readmissions, and we began our small tests of change. And in 2014, 2015, we now have over 20 organizations from the county and from also Prince George's County represented in our coalition. Delmarva is no longer our QIO. It's turned into VHQC, which stands for nothing but VHQC, in case you're wondering. And we've spread what we've done to other housing units. So Health Partners, our mission is initially to improve the transition of care from hospital to community for residents in the region. We wanted to reduce readmissions. We're expanding that now into population health. Once again, we thought this is great to prevent readmissions, but how can we prevent admissions altogether? How can we help people lead more healthier lives? So we want to sustain the community coalition. We want to be a vehicle for the patient and the family voice. We want to collaborate with all the organizations with shared visions and advance best practices, because there are a lot of things happening out there and people don't know, and they don't need to reinvent the wheel if we can help them do it. So our first site that we went into was Holly Hall, and it's an Housing Opportunity Commission property. Has 96 units with about 112 residents. There's an on-site resident counselor, which you'll see played in a lot to this. It was a fairly diverse population, mostly African American, and it was mostly people who were senior citizens, mostly non-Hispanic. But if you can see down there with your disabilities, we had a lot that were medically frail. We had a lot with physical and neurological disabilities, and some with cognitive. Although it wasn't captured here, there was a substantial number who also had behavioral health issues, along with any chronic conditions that they had. What we did was we looked to IHI to do any kind of change models that we're doing. So we looked at their test of change. We wanted to set aims. We wanted to establish measures. We wanted to select those changes, asking the three fundamental questions. What are we trying to accomplish? How are we going to know that we had a change? And then what are we going to do to make those changes sustainable? And doing this under the PDSA cycle. Data was very important to us because we really needed to know what was happening in our community. What were we dealing with here? So VHQC, although Delmarva did provide us data, theirs mostly was admissions and readmissions. VHQC took it to a different level. So they looked at the readmissions and the admissions. They looked at ED visits. They looked at number of days from discharge to readmission. They looked at your top diagnosis, and they focused on specific areas. They broke it down to Holly Hall. So we looked at an address. And when you looked at that, you could see, well, there were so many admissions, but that didn't tell the whole story. When you really looked at it, there were 4 people driving all the admissions and readmissions. So if you wanted to look at it, you might say, well, we need to plan an intervention on diabetes, but really you didn't. The intervention might have been, there might have been more people with high blood pressure, but those 4 diabetics were the ones that just kept getting admissions, and you needed to focus your attention on those, a small number of people. This is just an example of some of the information that they give us and how it's reported out to us. So into the most important thing is our resident engagement. Because, as I said, we wanted to involve the residents from the very beginning. I have a personal bias. I remember working for a company that was getting ready to do a takeover and all the secret meetings that were happening behind closed doors and you didn't know what was going on. And I felt this might be the way people felt. If we're meeting in their cafeteria, in their space, and there's a bunch of official-looking people coming in there, it's got to make them wonder what's going on, what's going to happen to me. So we invited residents to actually come and be on be members of our coalition, but we had resident meetings. We made this brochure so that they could have it, they could show it to their families, they could ask questions, they would know who to call and who to contact. And we did resident interviews to look and say, what is it you need? What do you want from us? How can we help you along the way? Our first meeting, and here's where the residents came in, and I'll give you a success story, is we were saying, well, we'll make a flyer and we'll put it out for everyone and they'll come to the meeting. And Martha said, that's not going to work. She said, you put flyers out all the time and no one comes to your meetings. She said, let's do an invitation that's in an envelope and I will hand deliver them. We got 60% of the residents to come to the meeting. They stayed in a crowded cafeteria for an hour and a half with 4 languages being translated. They were very engaged, and this made a huge difference, but it was getting the input from someone who knew what they were doing. Each of the residents has a file of life that they fill out and goes on their refrigerator. The file of life has demographics and your illnesses and meds, which most of the time the EMS tries to grab when they're taking someone out. But this file of life, the resident counselor goes up and actually helps them fill this out and has a copy that's kept in the office so that it's 2 places. And it's updated yearly. So it hopefully is current information on them. Now, what we did to help facilitate this is it's great that the resident counselor has the file of life and it's on the refrigerator. But if it's missed on the refrigerator and the hospitals can't talk to the resident counselor, all of that information is lost. So we did a very simple release of information that the hospitals would be able to talk to the resident counselor. We wanted the people to feel comfortable, so we said, we don't want your medical information. You wouldn't want your mortgage person to know your medical information. They don't want their resident people to know it. We just want to know, we can tell them, hey, they might have some problem with getting to the pharmacy. Maybe their family doesn't come as often as you'd like to see. They might need some home care. So we want to be able to help in facilitating your discharge so it's the most successful. And also, if the hospital can let me know, the resident counselor, when you're discharged, I can come up and say, is there anything you need? Can I help you in some way? So we also were able to get about 60% of them to sign these forms so that there could be that communication from the hospital to the resident counselor. Probably the biggest success is one of the people who's very active in our coalition is a pharmacist, and it's medication therapy management. For most people coming out of the hospital, and you'd mentioned MedRec, that's very important. You want to make sure that the meds they went in on or the meds they came out on or everything's been discontinued and restarted. But in a lot of cases, this isn't enough. You need a pharmacist who actually can go in and look at the meds and to be able to say, are you taking them? Is this a duplicate because you've got 2 generic names here or 2 meds, but they're both really the same medication? And follow up with their primary cares or the specialists. Some of the, just a couple little stories is one person that he went up who was going to the ER a lot would not take her blood pressure medication because she would not take a medication that was over 100 milligrams. Now, what he was able to do was get her on a different blood pressure medication that was 50 milligrams, and then she took the blood pressure medication. He wasn't going to get over that fixation as I'm not taking anything over 100 milligrams, so he was able to make that intervention and make that recommendation to the primary care who was able to order it. So, this is just really important. Another one, and he's always presenting when we have these meetings, and they flock to him afterwards. As a pharmacist, yes, I have questions. Another person said, I'm not taking this medication that my doctor gave me because I saw on TV they said it's going to give you kidney failure and kill you. Why does my doctor want to kill me? And this is a big problem that you don't think of, but when you see all those ads on TV as they trail off at the end, and if you die, your family might want to sue. And so it is scary. Yep, I'm just so. The other problem that we have are people order their meds from their families in South America or buy them from the little ethnic market that keeps the supply. So you really don't have any idea what those medications are. When you do this kind of pharmacy intervention, he's actually looking at them. He's in their house. He's talking to them. So that has been good. Another thing that we've had is our EMS now does an alert on a daily basis if there's activity. So it's not any protected health information. They're just saying, we had an activity at this address. Sometimes it's a car accident that happened outside, but it gives the resident manager an opportunity to go up and say, there's someone in this apartment. Do you need help? Is something happening? And he also gives us the EMS interventions for all of the places on a monthly basis so we can track how much EMS utilization is happening and should we do some kind of an intervention. We started this year for the first time for the Maryland School of Nursing is having nurses available for kind of a wellness clinic. They set up so that they can do health education, some screenings, assessments. They can do referral and follow-up or some case management. This is just beginning. We realized after the first year, and I talked with the instructor, she needs to develop more real protocols. These are RNs going back for an advanced degree, but what we thought that they could just take the ball and run with it wasn't so. So we're revamping that program, and hopefully that will be a success. Once again, before we did any of these interventions, we called the community together, and we let them know what was available for them. Technology. The software that we use to kind of monitor these patients in-house is a software system that it's just kind of a patient-centered. Here's the interventions I've done. Here's some of the referrals. Here's some of the barriers, so that different people can go in there. The pharmacist has access to that. The resident counselor and the nursing students will also have access to that to put in interventions and be able to track it, and different people can be seen. We're trying this community health gateway, which is a web-centered call station. This is one that the people have to be computer literate, but they can put a lot of their medical information in it. Their families can have access to it. Doctors can put information into it. Chris could eventually put information into it. Going a little slower, but I think that a lot of the people who are in the housing are a little bit computer challenged. So it's moving. So our successes, like I said, the biggest success is community engagement. Before we go into any housing, we have meetings. At our meetings, we have the hospitals present there, so the hospitals can say, here's what we can help you with. Here's our program. We're here for you. And we have had the residents become engaged. We have the hospital transition care teams working together. In Montgomery County, we have 6 hospitals now, all very good hospitals, all highly competitive hospitals. But our discharge planner said, you know what? We need to work together, because you see Joe Smith and I see Joe Smith and then someone else sees Joe Smith, and we've got to look and say, how can we work? All of us focus on Joe Smith so he doesn't come into any of our hospitals again. How can we do that? And so these discharge planners are meeting every month to work on what problems are that they see, and they report back to it. Our EMS is notifying us and giving us data so that, and they're actively involved too. Their plan is to, once the nursing gets up, and to actually go on visits with the nurses, to go in and say, I'm going to do a safety check. You know, is there something I can do to help you? The MTM, and I have on this one, and I didn't change it, it was an old slide, it's been over 20 patients that we've been able to have MTM on, and we would like to do that more. Our on-site nurses and the introduction of our technology in the system. And the one thing I wanted to bring up with our, we always talk about sustainability, and I'm done, is you noticed with the last presentation, she said we started out with a grant from here, and we started out with no grants and no funding. And in these last 4 years, we've had no grants and no funding. So I think that speaks to sustainability. It speaks to a community commitment. And although we will actively look for funding to try new things, the fact is we're engaged, we're involved, the hospitals, the community, and the residents, and that's what's going to sustain the project. And if you have any other questions, or if I can go into it more, certainly give me a call or email me.
Thank you, Mary Jane, very much, particularly coming with your poor functioning leg. So let me, if I can, turn this over to Shannon Hines, who many of you know since she's on our committee, and the director of the Regional Health Education Program, Health Promotion, and Women's Health at Kaiser Permanente, and she's on the phone. Kim, great.
I apologize for not being able to join you all in person again, but am happy to give you a brief overview of some of the successful patient engagement strategies that the organization has employed, and would also be interested in any follow-up information that the group would be interested in, because I'm representing the entire organization, but my component is only one of the spokes of the wheel in terms of who's actually, involved in this kind of implementation. So I'll be speaking briefly about how our case management team is doing some great work around employing navigators to help assist in connecting patients to social services. Obviously, quite a bit of the work that's being driven is actually being done by our healthcare teams, and that includes physicians. It includes clinical pharmacists, as many of the other folks have indicated are very important to the team, registered dietitians. So I'm kind of one of the groups that helps to support this, but I'm in no way the only one who is really engaged in this and would be interested in what follow-up information the group would like to see, and then perhaps I can invite some of those individuals to join us. To give you a brief overview of the organization, Kaiser Permanente is an integrated delivery system that provides care to members in the D.C., suburban Maryland, Baltimore, and Northern Virginia area. We're providing care and coverage to now over 600,000 members, and most recently have become a managed care provider for the states of Maryland and Virginia. In the entire service area, we have 32 medical centers that provide primary, specialty, and ancillary services. Some of the larger facilities also provide urgent care and some emergency care that can be taken care of in a 24-hour period through a unit called the Clinical Decision Area. My Health Education, Health Promotion, and Women's Health team specifically provides patient engagement programs and tools that are promoted directly to members and also integrated and used by healthcare teams as part of the patient experience. One of the things that we have learned over the years is we can do quite a bit of direct consumer engagement activities, but the ones that we find most successful and most meaningful and most integrated are the ones that the teams are really engaged in with patients. So our primary, I would say, promotional path is to get our healthcare teams really talking about these programs and encouraging patient commitment and engagement in them, and really having that shared decision-making conversation with the patient. We do quite a bit of direct member outreach, but we find more success in those that the physician and clinicians and other healthcare team members are intimately involved in and can get the patient's buy-in to participate in actively. And then my team also oversees the preventive health and self-management programs. There were some comments earlier around things like the chronic disease self-management program and those kinds of, I would say, disease management or self-management tools, and those are the components that my team is managing on the regional level. We've also found that in order to make the integration of our programs as easy and seamless as possible for our providers, we've embedded them into the electronic medical record. We're using the EPIC platform within Kaiser Permanente. And really that patient-facing work is done by our healthcare teams, and that includes our primary and specialty physicians and their support staff. And one of the groups, as I alluded to earlier, that I'll talk briefly about is our case management team. We have a clinical screener that really helps to look at all the referrals to case management, and those can either be by a physician or another healthcare team member or self-referral by the member. The clinical screener from that point really helps to navigate the patient to the right set of resources. Most likely will be a case manager to really case find and identify what are the specific needs of the member. And then once the member chart is reviewed, next steps are really confirmed, and this new set of navigators that have recently come on board. We have 11 of them that have been hired. We really think is vital to help connect members to social services and really get those members connected to the resources that they need to meet, as one of our previous speakers indicated, meet their basic needs before they can really begin to engage in their health care needs. So the navigators are really going to be able to help us do this. And what we really see them doing is working directly with the case management team and also with our primary care physicians, sharing important community resources and practices, and also helping actually meet members in person at medical appointments and really helping them to navigate through the healthcare system. And I would see them really being a key integrator for all of the work that we've been discussing through this specific group. In terms of other kinds of tools that we've used for patient engagement and things that we found success with, we do quite a bit of what we call in-reach, which is really identifying members who have gaps in care and getting them connected to services when they're in person with us. And we use every opportunity when members come in to really get them connected to those types of activities because we want to catch them when they're present. For example, if a member is coming in for let's say they're coming in for an OBGYN visit, the OBGYN physician is also looking for other care needs. They are recommending that the patient get, for example, colorectal cancer screening if they're age 50 and over, and some of this stuff just may not be kind of routine for that specialty, but we set the expectation that we want to close these care gaps when the member is present and really help to take care of those health care needs when they are actually physically there. So that's been extremely successful for us, really being able to take care of all those things when the member is there, and we can really take advantage of that opportunity. We're also offering information in multiple modalities and being respectful of diverse audiences, finding ways to actually connect patients throughout the continuum and using things other than in-person visits. We do quite a bit of work using registries and strong analytics to ID populations of patients that can really benefit from services and outreaching to them through telephone or also secure messaging to get them engaged in their care. We're doing quite a bit of work, as previously indicated from our other speakers, around focused populations, diabetes patients, for example, high utilizers. We're looking at equitable care measures and really utilizing the chronic care model and patient care center approaches. We are certainly looking at the voice of the customer and find that to be extremely important and valuable through patient advisory councils, member voice panels, and really helping patients to be intimately involved in the development of programs, so again that there's lots of buy-in from our patients. And then in terms of actual training of clinicians, we're also using motivational interviewing and training our healthcare teams around shared decision-making approaches. And then in terms of guidelines, we have clear and simple communication principles that guide the development of our content. And we've just recently created a behavior change principles communication guide that really is going to be helpful for our health education efforts to really write content in a way that's targeted to the specific audience and adds behavioral nudges to really help move patients along the continuum. And this is a lot of the BJ Fogg work around behavior design that went into designing the specific communication guide. And I'll close, because I'm sure I'm close to being out of time, with again, I'm happy to connect any of my clinical colleagues to the group and bring them before the group to share some of their best practices and their metrics. And we have the same goals in mind. We want to provide better care, quality care, more cost-effective care. We don't want patients to continually come in and out of the hospitals, and certainly want to stay connected to this work and feel like the direction that this group is moving in is also in alignment with Kaiser Permanente's mission, vision, and values.
Great. Thank you very much, Shannon.
Thank you.
Maybe now we could open it up for members with questions.
Hi, this is Diane with HSCRC. I want to direct a question to Shannon. Thank you so much for the presentation. All three speakers that were wonderful, really inspiring, I think, and hopeful. So Shannon, can you speak to sort of the scope of your programs in terms of, you said the membership's at 600,000 in the metro area. Just curious about who you define as the highest level need, and then what sorts of outcome data have you seen from these various interventions?
Great, thanks for your question. So we're looking at a variety of different pieces of data. Certainly we do monitor our HEDIS performance and use that to help identify where we may have opportunities for improvement. And what we're doing with the HEDIS data is we're also mapping that to our diversity language data so that we're looking at how are we performing on some of those key HEDIS measures and how do we compare in terms of population. So are we seeing a disparity in care? And really use that information to help us to determine what our priorities are for each year. For example, this year we've picked blood pressure control in African Americans as a key measure because we see that there's a slight variance in how we're performing with the rest of the population compared to African Americans. So we can use the HEDIS data for that component. We also do look at top diagnoses that come in at least on an annual basis, and we're looking at that, comparing our various populations. We have certainly quite a large commercial market, but we have a very large emerging Medicaid market, and comparing what do those diagnoses look like and what do we need to be doing differently is certainly something that we're focused on. My population care management colleagues are doing many kind of small tests of change along with our clinical health care teams and looking, I would say specifically at those higher chronic conditions in terms of prevalence and incidence. Things like diabetes continue to be on our radar and doing some really specific and focused interventions around those areas continue to be important. CKD is another area that we're focused on. Depression is an area that we're focused on. I don't have the performance off the top of my head. I know that we're doing fairly well, but not as well as we would like to be doing, so I can follow up with my population care management folks and get some more specific details around what those interventions are. I know that we're doing quite a bit through the clinical pharmacists. We're doing a focused work through the EMR, really helping to identify where we can embed best practice alerts and other kinds of decision support tools in the electronic medical record, but would offer to get that back from my population care management colleagues and be able to provide that follow-up information along with the associated outcomes.
That sounds perfect. Thank you.
You're welcome.
I'd like to ask a couple of questions of Becky. On chronic disease case management, you have 2 teams for 3 counties, and I was curious how many cases a team can handle or does handle where they actually are engaged with the patient as opposed to saying we have this many residents in the county.
Right. When we started this program, we looked at Hopkins model as well for care management, and their model looked at 60 per team. That's sort of blended, though. You know, you can have some that need minimal interventions, and then you're going, segment of that case load is going to need a little bit heavier. So we're looking at this point in time in between 60 and 100. Right now we're at 92 total enrolled. Our Worcester and Somerset County team are carrying a little bit more. They're carrying about 50, whereas our Wycomico County team is carrying the other 42.
Okay. The second question I had was you indicated that you check on medication reconciliation with CRISP to see whether meds are being filled or not. How reliable are you finding the CRISP data?
It's good. It could be better, because certainly, it's only as good as the information that's being put into it. Hopefully everyone, the majority of our facilities are utilizing that data, but are utilizing this system. We use the CRISP not only for that, but more for information regarding their hospitalizations, their ED visits. When we do the med reconciliation, the nurse sits down with the patient and says, let me see all of your meds that you have right now. And so they bring out the bag and they put them all out. And then, okay, let me see, your latest ED discharge, and let's see what they prescribed. We match those 2 up. In addition to, let's talk with the primary care physician because you need to see he or she within, we like to get them in about 7 to 10 days after their ED discharge or their hospital discharge because that's the sort of critical time when they're going to go back into. So we use all of those. It's just not one system because you have to.
what I was chasing was whether the commercial pharmacies are reporting their sales through CRISP, so that you can see whether the fill rates were any good.
I don't think they are, Gary. I think the thing that is consistently reported to CRISP around medication are the scheduled drugs.
They are.
And there's a central statewide management of the scheduled drugs just to look at polypharmacy and those kinds of things. But the regular pharmacy management companies that are serving most of the commercials, I don't believe report into CRISP.
It is more for the scheduled, the controlled.
Yeah.
Because there is certainly, I think in any jurisdiction, there's concern for that.
Anything else, Gary?
Yes, Kim.
I have a question.
Okay, who is that? Who is I?
Michelle from CASA.
Good, thank you. Go right ahead.
I was wondering what the capacity was to do the community engagement in other languages other than Spanish or English.
Is that directed at one of them in particular or in general?
Either one or two is fine.
You each want to take a crack at it and identify yourself because she can't see you?
Yes, this is Mary Joseph from Primary Care. When we did that, we looked at the most prevalent languages, and I think that we found 4. And so we actually had translators for the community who were translating the message to them. We try to put any materials out to hit the languages that are spoken. And in the housing, we're seeing there's generally between 4 and 5 languages that are spoken there, and we realize that we have to put the information out in their languages.
Becky, you want to?
Hi, this is Becky. We primarily have one language other than English in our Tri-County area. We do have literature that is available for that language. We also, through the Worcester County Health Department, have an LEP policy, which is a limited English proficiency. So we have a variety of resources and protocols depending on the need of the client. We do have translators that are on a consultant basis that we can call and schedule and bring in to help us communicate with the client, and that includes sign language as well. We have had that instance.
Shannon,
yes.
Are you? Yeah.
I am here. I would say that we are doing some things, but I wouldn't say that we're doing everything that I would think is required to engage members who speak other languages. I think that we have made the most progress with Spanish because that's the highest language in our membership that we need to address. I would say that all of the things that we're doing from a consumer engagement standpoint, we have literature, we have qualified bilingual staff, we have pieces of it, but I think that there's still a lot of work that needs to be done. This is kind of a different population, and as we get more and more into the Medicaid market, I think that we're discovering that things that we have been kind of traditionally doing for the more commercial market, we need to be more creative and move to having more community health workers, which is why we brought in the navigators and doing outreach in other ways. So I think that we are making changes to our approach and need to be doing more for populations that are where their predominant language is not English. I think we have a long way to go. We're certainly doing some things, but would say that we have work to do to really do that well.
Thank you, Shannon. I wonder if any of you take your written materials and have them, or are they either initially on the team preparing them somebody with a knowledge of health literacy and plain language? Are they vetted through that process in some way before they are used with your patients?
Yes, this is Shannon. They are in our process. My team is actually interesting. We were just having a conversation earlier today about how we've been engaged as kind of the health literacy experts across the program, and because there's such a need for all sorts of documents and content ranging from discharge to consent forms and even things that are out of the scope of health education, and people don't necessarily have that background or expertise or competency to be able to do that. So we've been doing a lot of that work for the organization, but really getting the clear and simple principles out to our departments is really important to us because we're a small team and can't certainly do it all. But we do, on my team, in addition to using kind of the basic principles and formulas that are available to us, we also have invested in the health literacy advisor software fairly recently as an additional support tool for the team. So in addition to being trained and really understanding how do you put together a document and the kind of the basic principles around making a document health literate and actionable, we've taken another step and invested in a software package to really help to facilitate that process.
That's great. Thank you.
And that's prior to the translation.
Right. Good. Okay.
This is Mary from Primary Care. We haven't really put out any literature other than our release of information. But on another grant, we were doing a very simple flyer for people, and it was amazing. The first run-through that came back from a marketing department was over a 12th grade level. And it took a long time to get it down to a level where it was acceptable to all for patients to actually read. So I think it's just a cautionary thing. It may look simple to you, but it really isn't. And you really have to go back and redo it many times.
So at the June 5th subgroup meeting, 9 to 11 at MHA, Linda Alduri from the University of Maryland Health Literacy, is going to be doing a presentation on health literacy. And for those who aren't there, there will be the ability to call in. I'm right on that, aren't I, Tiffany? Good. Okay. So I just want to mention that. Any other questions? Yes, Kim.
Turn green. Sorry. I've been trying to figure out how to formulate this into a question, and I'm not sure that I can, so I just want to kind of tell a story about what happened yesterday when I answered a call from, by the way, for those on the phone, this is Kim Burton. I work for the Mental Health Association in Maryland, and my niche of that is geriatrics. So I get a call yesterday that is common to lots of calls that I take, and it's a woman who's in her late 60s, and Shannon, so she has Kaiser Permanente, but this could be absolutely any insurance that folks have. And she's somewhat cognitively impaired, but mostly she's like saying to me, I'm just kind of a person and my insurance is really big and I don't really know. When I call, I don't talk to a person. And her particular situation, she had moved from Pennsylvania. She'd always been diagnosed as having chronic depression, but her new psychiatrist at Kaiser says she has bipolar disorder. And so she's really kind of concerned about that, and she doesn't know about her medications. And I mean, she was just obviously needed better communication skills to talk with her doctor, but she felt really intimidated. And I asked her about other support because it's so important for people with mental health issues. They get their pills from a psychiatrist, they get their everything else support from a therapist, but they don't always understand what that looks like because the whole mental health system is so confusing to people. So she said, well, she has seen her therapist, but she doesn't really like her therapist, but the woman's very nice and she doesn't want to hurt her feelings. So this goes to kind of the culture of aging, of a person who isn't willing or ready or understanding that she kind of has rights to ask questions and make different choices. So she kind of feels like, well, these are the things that I'm given, but so she starts crying and she says, but I don't really fit anywhere and I don't know why, but I don't want to go out and do anything anymore. And my daughter's so nice and her husband's so nice and they do everything for me, but I'm not, but I think I'm at the end, is what she said. So she was just kind of feeling in this place of despair. And our job at the Mental Health Association is to try and figure out where to guide them. And so I'm trying to guide her back to Kaiser, but she's intimidated. And I think I hear Shannon talk, I hear everybody talk, and it's fantastic programs, really. Like, it covers everything, soup to nuts, that anybody could ever need or want. But then there's a disconnect somehow along the line. And what it comes down to, a lot of the people that I speak with personally, is that they're kind of wondering where that person is that they can call. Because if they call a number and they get an automated thing, it feels confusing and it feels scary to them. And so they end up backing out. So clearly, the reach needs to come so that person can really understand what's available to her, because it sounds like there's a ton of things available to her. But then I, as a community agency, when she calls me, I can't tell her what's available at Kaiser or any of the other health organizations to which they may belong. But I can say, here's what's going on at the Area Agency on Aging. They have a chronic disease self-management program called Living Well. They have, so I know about the Area Agencies on Aging and how to connect them with Maryland Access Point and that kind of thing. And while she was willing to take these numbers, I have doubt that she'll call many of them by virtue of the disease of depression, just feeling overwhelmed, feeling like that phone is 200 pounds and they can't pick it up. She asked me several times the same kinds of questions, so that could be an inability to focus or confusion from depression, but it also could be cognitive impairment, which is a huge growing issue. And if we're expecting consumers to be able to engage, but they don't have the cognitive capacity to do so, we might be missing the boat. And that kind of goes to literacy. I think sometimes we think about literacy in terms of grade level, but what about literacy in terms of cognitive impairment? So you see how there's like a ton of issues involved in that one scenario, but that's a scenario that comes to me maybe a couple of times a week. So I guess part of me is curious about, part of me wants to just tell you how multifaceted this is. Part of me wants to see how you might engage. I know kind of how this happens in your program because I know the Area Agency on Aging down there is so incredibly powerful. But where these programs that exist in the community, in the senior centers and so forth, but if they're, the example of this woman through Kaiser, she's not getting information about the programs that are happening in the different senior centers in her area that might help her with just social engagement is kind of what she needs, or a peer program. So there you go. There's no question in there, I don't think. But if anybody wants to speak to any of those kinds of things, like how there's lots of gaps there to be bridged. So
what I can speak to is we talk about patient engagement. We also have to talk about family and caregiver engagement, because sometimes no matter how much you try to engage the patient, they aren't able to engage, but the family is still there. The family is still facing whatever illness, because most illnesses involve a whole family. It's not just one person. Ask my husband after this leg, he'll tell you for a long time. But it really does. It is a family-type dynamic, and you really have to engage the family. And who in the family, just because the son comes to pick someone up doesn't mean he's going to be the one who's going to be engaged with. You've got to find that level who's going to really be helping this patient throughout whatever the illness it is.
This is Donna Jacobs from the University of Maryland Medical System. Kim, thank you for that story. And I would suspect that for all of us, it's not that foreign. And there are so many levels and so many things embedded in what you said. Part of it is it reminds us really of the magnitude of the problem, of the issues that we're confronting, and how many people are dealing with things that may be invisible to many of us. And no matter how good, how thorough, and how thoughtful the programs are, it's still easy to miss people. And we have to be very careful about that. So, but it also says what your story says to me is that when we think about consumer engagement, we also have to think on the other side about us as providers and how we're doing a better job now. We're beginning to sharing information across what previously was really siloed work. And so people didn't understand. No one else knew what you were doing within your hospital or within your FQHC or your agency or whatever. I think we're beginning to talk across borders, and that's a very, very good thing. And one of the speakers here in the room referred to trying to capture all opportunities, or somebody did. Somebody talked about the OB example of talk about colorectal screening when they're there for an OB screening. I think we have to think in terms of no wrong portal. So wherever the patient accesses an opportunity for care, we're able to direct, give them the resources that they may need, even if it isn't our program, and even if it's someplace else. So we need to really think about where do we and how do we house some central place where information is available to all of us, because we are going to keep dealing with the same patients, certainly within the same geography, over and over and over, who are confronting the same.
Thank you, Donna. Unfortunately, I'm mindful of the clock. So, but the idea of the no wrong portal, all of the presenters brought up the social determinants that are such issues too, and getting to the no wrong door between health and social services. I think it's all part of what we have to be thinking about, and also raised by Kim's. So we need to move on. I want to thank both Becky and Mary Jane and Shannon on the phone for very useful, and for we've got the paper copies. We know where to find you. We're more than happy to have you stay. This is we're going to talk a little bit more about some of the other areas that we're looking at for this particular group. So, as I say, we're happy to keep you or let you go. Okay. So I want to turn, if I may, to Suzanne for an update on the forums.
Everyone hear me? I have a cold, so. But anyway, thank you for this time to update you on our progress. We've now had public forums in Howard County, Prince George's County, Carroll, Frederick, Lower Shore, Mid Shore, and since our last meeting, we've had forums in Southern Maryland with Charles County and in Western Maryland in Allegheny County. The first was on the 20th at Charles County, and you have some materials from that in the meeting packet here. This one was a bit unique. It was at a local high school, and they had AIDS quilts visiting. We got to see that, and that entered into some of the conversations. We also had the pleasure of having Lenny and Michelle Clark, who are both members of this group, with us, and Carmela Coyle gave the presentation on behalf of the Maryland Hospital Association that kind of gave the background of what the waiver looks like and other things like that. The local health officer had some wonderful updates on the great work of the health department there. We also had a representative from Community Catalyst come and talk very briefly about how this fits in kind of from a national perspective of all the great, incredible work that's going on here in Maryland and how the rest of the country is looking at us as an example. So we had about 65 attendees at that. We also had the new Secretary of Health, Secretary Van Mitchell was there, shared some thoughts and fielded some questions. That was before we knew how the governor was going to handle the budget situation. So there were some good questions with that. This is actually the first forum with the evaluations where hearing about health system transformation via social media was the top-ranked sort of channel for getting their feedback, learning about the programs that are available and how to plug in. At all of the other forums so far, the primary care physician, their local doctor, has been the top-ranked one. So I thought that was an interesting sort of unique finding with this particular forum. We still think that working with primary care providers is going to be a very important next step in taking this message forward. But, you know, Southern Maryland really likes their social media, so we can learn from that. There was also a very strong representation from the local health department in those responses as well, just to be noted. And the next forum we have was in Western Maryland at the Western Maryland Health Systems in Allegheny County. And that one was also pretty unique because they've already been operating under a global budget structure for several years. So a lot of the attendees were already kind of familiar with some of these concepts and the different strategies and different collaborations that resulted from sort of the redesign of how that's working. We had about 25 people at that one. It was at one of their regular meetings that they have already at the hospital with local community leaders, particularly from the faith community, and definitely echoed the themes that we're talking about around this table as far as social determinants of health, as far as poverty being the biggest barrier to leading a healthy life in Western Maryland, and really had some very interesting examples shared from faith leaders about how they've been a conduit to really taking a hard look at the poverty in the communities that they serve and how their role has been to connecting those who most need the health care to the incredible health system that they have built over at Western Maryland Health System, and Tri-State Federally Qualified Health Center was represented as well. And a lot of folks from Healthy Howard were there, so it was interesting to see that. They talked about some of the mini grants that they've been able to funnel to the community through the Western Maryland Health Systems and the hospital, and how they've been using that to sort of promote some public health messages, particularly on tobacco use. And they also shared some information about the new ACO that they're working on developing and how that's kind of a continuation of the work that they've got started under the global budgets there. As a next step for them, they will be having Reverend Reddix, who often presents with me on the Faith Community Health Network that I'm sure you've heard about already. She is going to be at their next meeting this June. So they're really looking at really implementing something like that in Western Maryland as well. And we're excited to hear about that. Our next steps, we've already engaged over 300 Marylanders through these forums so far, and we're really excited about that. The valuable feedback that you can see here, and I believe on Basecamp, I think I've uploaded all of the evaluation summaries soon after each of the forums are held if you want to take a look at those. It's been great feedback in helping us fine-tune our messaging and approach. We still have 4 more forums coming up in Baltimore County next week on Tuesday, and in Montgomery County, Anne Arundel County, and Baltimore City. We're still working on looking at a second date for Baltimore City, so stay tuned for that. But all of the dates and logistics for all of those forums are on Basecamp. And if you have any questions or you want RSVP, we'd love to have you, or anyone else that you know of that you'd want to refer to talk to sort of get their feet wet or really jump in. The vast majority of the people who come to these forums, this is the first time they've heard about the all-payer waiver or health system transformation and some of the great programs that are going on in their communities that they don't know about. So it's a really great first entry point for those who want to get more involved. And our second update is that LifeBridge Health is definitely interested in implementing a faith community health network, and we're going to be very involved in working with that and mobilizing the faith community that's part of our Healthcare for All coalition in support of that effort as well. So, and LifeBridge Health includes Carroll Hospital Center, who came and presented at one of our presentations, as well as Northwest and Sinai.
Great, thank you, Suzanne. I should say that Kim, who's sitting behind Suzanne, is collating the responses from the evaluation so that we'll be able to take an analytic look at those. And so
we'll be producing a report as well.
Yeah, so but we won't have those findings in their entirety for the preliminary report that we're putting in July because of the timing issue. So some of that will feed into how we build out that report for the final report in September. So do you want to talk about the...
So just a brief update on the combined subgroup. We have the Consumer Engagement Task Force and the Consumer Outreach Task Force has a small subgroup that looks at the evaluations from the forums and looks at opportunities to apply those learnings for our future work. And so at our last meeting, we talked about the evaluations that Suzanne just reviewed for us. And we decided that we're seeing some triangulation in some of the questions, and so there was an opportunity to possibly revise the question. And we came up with a question. There was some discussion in our subgroup from this task force about the information that we'd like to gather and potential follow-up. And so very recently, Suzanne and I conferred, and we wanted to offer a question to the group to see if you think that that's a question that would make sense for this, and then also brainstorm briefly around some possible responses to those questions, or to that question. And the other thing that we'd like to share is that this task force will now be represented at the Healthcare for All Forum. So we've been featuring updates from the Healthcare for All forums, I guess at all of these meetings. And so we talked about, what way that we could share information about what the next steps are. And so Healthcare for All does share the next steps and what their initiatives will be, when it's going to look like beyond the report that they give to the Commission. But we haven't talked a lot about this consumer engagement group and how our work kind of works together and intertwines. And so we'll be speaking briefly, about 5 minutes at the end of the Healthcare for All forums, about this group, the relationship to the task force, and then how we'll be working together to move forward. So we'll be represented at all of the future ones, hopefully, and I'll be sharing the draft presentation with Healthcare for All and also with the members of the task force to make sure that we're covering all the bases. But it's nothing new. So, did you have a question?
Well, I did, because the next one is the 2nd of June, so you said there would be representation. I was just wondering who was representing.
So I told you in an email that no one will be represented.
Okay, so I just want to clarify that for everybody. So there won't be representation actually at the next one. No. Am I right? Okay.
Okay, sorry. Since the date's coming up quick, Steve has agreed to represent.
Oh, terrific. Well, thank you. So we can talk about that offline.
Yeah.
And we can work it out.
Yeah, so if you could share with me a few slides, I'll include it in my presentation.
That'd be terrific. Thanks.
Right. And I also am going, so if Steve is not inclined, or I'd be able to do it as well. Okay, so we'll work it out.
We'll work it out.
Yeah. So that'll be great.
Thank you.
And the new question, well, is that?
It's just a draft question, and I can throw it out, and people can spend a couple minutes reacting to it. Is that fine?
Sure. We're running a little behind that. So
don't we have an agenda item about that, and we included the evaluations? So do you want to do that later?
No, you can go ahead and do it now.
Okay. So there's the question number 4. Question number 4 says, in what ways do you think your constituents might want to be involved in implementing Maryland's health system transformation? So if we're looking at the last document, so it may be like the 5th from the last page is in the summary of the evaluation, but I can read it to you. We just ask in what ways do we think constituents might want to be involved, and for most of these forums, they've said that they'd want to be more active and knowledgeable in their own health care, and also to be more knowledgeable about healthcare services and options that they can have to improve their health. So we thought that a good follow-up question to that would be, what do you think consumers need to enhance their engagement in their own care? So that because the responses have been that consumers want to be more engaged, what do we think they need? What tools, what resources do these folks think that consumers need to be more engaged? So that's the question.
Where would it?
Sorry. Okay. So there it is, right at the bottom.
Okay.
In what ways do you think you have your magnifying glass?
Yeah.
But, so question number 4. But we're not replacing it. We're just proposing a follow-up. So the responses have been that they think that consumers can be more engaged, or that they want to be more engaged and they want to be more actively involved. And so we thought that an appropriate follow-up question would be, what tools do they need? What resources do they need to actually be more engaged? That's what we're proposing. So number 6 is the one that we saw a lot of triangulation, and so we felt like we could just leave that one out. And number 6 was just asking, when do you think is the best time for the state and hospitals to inform the public about the health system transformation? And most people said now, and every time new information becomes available. So we thought, no-brainer, we'll just get rid of that one and insert a question that can be more informative and guide some of our work. So any thoughts about possible responses for that proposed question? So the question is, what do you think consumers need to enhance engagement for their own health care? And so we just want to offer some categorical responses that, you know, what resources do you think people need, what information people might need, what tools? What about, like, educational?
Is it, sorry, Hillary, just one. There's a difference between the type of information and tools or resources. Seems to me that's almost two questions, really. And I think maybe that was part of what was discussed at the subgroup meeting. I'm sorry, Hillary, go ahead.
I was going to say something very much along those lines, that because different patients will have very different specific information needs, it may be better to frame it in terms of exactly what resources, what formats would be most useful, and so we could sort of throw out the various types of formats from, you know, printed material and brochures, sit-down conversation with a care manager, send me an SMS when it's time to take my pill, you know, and we will probably have people on all ends of that spectrum given the diversity of the population in the state and their needs.
And I think at the subgroup we talked about the type of information with some categories around patient rights, maybe with some specifics, to go back to the three areas that if the websites have been surveyed, the consumer feedback, the care coordination, preventive care, are those the areas that they need more information on? So, the question...
If you ask it more generally, as you were talking about, and say what resources would be helpful to you in order to engage, then both information and tools that people might want to suggest could be listed. And if you say it as most useful, it would be kind of in the format that some of these others have been, that you could pick one, pick two, and be able to look at, how do I register a complaint, how do I, you know, whatever it is you want to put in the list, and they can all fit together, even though it's kind of two different subsections, because you're asking them what would be the most useful or what would be the most helpful resources in being more engaged.
Any thoughts about that, a more general approach?
Well, and I guess I'm struggling with understanding whether we're interested in finding out more information about engagement in their personal health versus engagement in understanding the changes occurring in the Maryland, there's that term that's using, that Maryland's health system transformation. And so that was my question. Are we going beyond just being aware of Maryland's healthcare system transformation? And then the other comment was, I'm not sure I would know what to do with those responses. So I think I'd still be in a quandary as to, okay, so now I have those responses, but it's still not actionable for me. Those responses, the assessment of the responses and analysis, I'm still not sure it would provide something actionable for me or for this committee. But.
So your first question, so this would be a follow-up to question number 4. So with the responses that we've been receiving is that people want to be more engaged in their own health care, or at least their community leaders think that the constituents would want to be more involved. And so not in the all-payer model, but just in their own personal health care. And so the follow-up question would be, in what ways do you think, what tools, resources, what do people need in order to be more engaged? And so someone has suggested information. Hillary suggesting a more specific approach to offer different tools, specific tools, resources. Okay. Right. So we can just merge them together. Okay.
And just to go to your question, Barbara, so the evaluation as originally conceived was more around the sort of new all-payer model transformation, and they were kind enough to add some questions that would get us some of the information that we, this task force, need. So are we okay with? Good. Okay. So let me just quickly try to get back on schedule and sort of report out, if I can, from the work that the subgroup did and the presentations that we had the last time, whenever that was, 2 weeks ago or a week ago, which were looking at our sort of charge to piece and the ability for consumer feedback and PFACs, what's happening on the ground. So Renee Webster with the Office of Healthcare Quality came and talked to us about that process. And then Jeannie Morris with the Anne Arundel County Medical Center came and talked about the work that they've been doing around PFAC and patient and family engagement. Really interesting presentation, and they've been using the ARC toolkit that everybody should have been getting the links to, and which Novella and Teresa in particular have taken a closer look at that to see. I think everybody's agreed that it's a very useful tool, but are there some things that if we were to recommend that as one model, there should be things that should be added. Do you want to, since Teresa's left us?
Sure. So in terms of internal organizational tools for increased family and patient engagement, I think it's a great tool. However, one of the things that I thought was missing was the global community engagement, policy level engagement. You know, this really kind of underscores what Kim was talking about. You know, when someone's not necessarily in that healthcare organization at that time, this tool doesn't give us a means to engage them outside of being internal in this organization and really being involved of this particular organizational policies. I think for this group, we're looking at a more global perspective of engaging the entire community in different, you know, no wrong door kind of approach. And so to add anything, I would add something that was more inclusive of not just an internal organization, but was expanded to include community level and policy level engagement.
The other piece noted missing was any sort of evaluative process for the toolkit and its use. So I think that was, we felt, was on the table. And then since we've been circulating some other tools that would be useful along these same lines, including the Partnering with Patients and Families to Enhance Safety and Quality from the Institute for Patient and Family-Centered Care. And then the Informed Patient Institute has developed for 5 states, I think it is, some tips for patients and families around hospitals, doctors, and long-term care facilities. And so I'll be sure that all of that goes up on Basecamp, and so we can take a look at those, because one of our recommendations may be to suggest that Maryland should be the 6th state. And I know Teresa was saying that that would be something that they could put up on their website as a consumer tool. So, and there were some other recommendations around that area too. So I'll make sure that all of that goes up, and it could I'll get it into the minutes that Tiffany can circulate. Deborah Millen from MedStar also presented on the same topics. They're not as far along. They have a much bigger system to deal with. But the other presentation I just want to mention was Nicole Stallings at MHA presented on a survey that they did in 2013. They surveyed all of the hospitals and got 30 responses with some questions that are relevant for the work that we're doing. One of the questions was, does your hospital have a functioning PFAC? And the answer was 40% said yes, 20.5% said that they were working on it within the next year, and 44.5% said no, they didn't. So I think that there's a lot of opportunity for us to make some good recommendations in this area. Then Michelle Craig looked at the survey because Nicole was open to adding some more consumer engagement type questions for the next go-round. So Michelle had some suggestions. One was, do you have a formalized process to become a patient advisor? And the other, and Michelle sends her apologies for not being here so she can say this in person. The other was, are consumers engaged directly in advising changes at your hospital? So this goes to what Novella was saying about the policy piece, and has a feedback loop from patients directly impacted. And then she had some specifics. So I think those are useful suggestions that we can take to the next subgroup meeting and build out from that, and then bring back to everybody as part of the recommendations.
Lenny, if I might
Yes.
comment, I appreciate the work that you and others have done to find sites that are currently doing things that we would find useful. Because to the extent that we can use existing sites and make them more successful, it helps both them and us. We can eventually have a localized Maryland site that has references to these things and not have to do the upkeep on them from time to time as we would have to if we create a site. So it's really useful, I think, to be able to tie in some of these resources. And I've been going to them and looking at them and finding a place that has automated addresses filled in for you if you're in the state of Maryland and how you want to go about lodging a complaint.
Mm-hmm.
I would like to suggest to them they could go one better and put a downloadable letter in format with the address on it, with problem, date, and the material, so it'd be very easy for you to fill it out, as opposed to, I have my senator's address. How often do I use it? So that kind of thing is something I think that as we help to put this system together, to the extent we can use existing resources, it would be great to be able to use them and not have to recreate them.
And maybe since HSCRC has such a great site, they can host the consumer engagement website for all of us, right? I'm just...
Maybe MHCC seems to be the logical place. They're broader, as a broader
yeah, I was
audience
just teasing.
and so forth.
I was just...
But we would link to that. Certainly, we would link to that.
Yeah, so that's an interesting... Thank you. Any other thoughts on that? Okay, so that sort of addressed the Charge 2 work that we're doing. So we'll move on to the Charge 1, which I think has been challenging in figuring out who the audiences are and defining this a bit more. And Hillary, some time ago, had done some work to look at prioritizing and identifying around geographic areas. And then with the regional partnership grants that HSCRC just announced, in which you got the link for at our last meeting, we discussed whether there was a way to leverage those in some way with the work that we're doing. And so Steve was kind enough to give us a short update on that. Doesn't have to be that short, Steve.
Well, I will avoid the whip as best I can. So you may have heard that the Commission had authorized up to $15 million in rates. We call this BRFA, it's the budget out of the Budget Reconciliation and Financing Act. And the Care Coordination Work Group really looked at kind of three buckets, really two buckets for the purpose. Not just this money, but other resources that could come to bear. And they are statewide infrastructure to help support, all collaborations around the state, all hospitals, partnerships to provide analytics and data. But then also to start with, the beginning, if you will, with planning. And obviously, partnerships are not just partnerships between a hospital and the community partners, but it's also, many hospitals share the same population base, target population, the same folks, chronic illnesses go to different hospitals. We want hospitals to also collaborate among themselves. So we set aside of the $15 million, $2.5 million for these planning grants so that hospitals can begin to talk and put together a plan so that by the end of this year they'd be prepared and ready for actually implementation of care coordination, good care coordination activities. as I mentioned, so 2.5 of this was for the regional planning grants, designed for, as I mentioned, data analytics and strategic planning. We brought together a very broad stakeholder group. Some folks in this room were part of that process. Thanks, Lenny, and I know there are others, Kim and maybe it. But we did a robust review of all of these, and the group recommended and the commission approved 8 of the 11 proposals that came to us, and the amounts, again, this is for planning, the amounts range from $200,000 to $400,000. We got some really nice proposals. Some were really well developed because, you know, you've heard from, you know, Montgomery County today. They have some well-developed partnerships. There were some others where they're just starting from scratch, and the group wanted to support that because they've had challenges in trying to bring the community partners together. We want to be able to support that. So they range from $200,000 to $400,000, and the reports are due there's a preliminary report, I think, in October, and a final report in December. This will dovetail into something the Commission is looking at right now, and that is in the update factor, including 0.4 for all hospitals for infrastructure support for implementation, and another competitive process for 0.25. So I'm using numbers, but I'm using percentages. 0.25 is about $40 million in the system that could be used for competitive grants for implementation. I want to emphasize that it's not geared toward those who have planning grants. It's any partnership that meets, you know, that meets the triple aim and meets the goals of the new all-payer model can, you know, qualify for this. So we encourage hospitals and partnerships that didn't get something, whether they applied or not, to continue this collaboration, because there can be some implementation funds at the end in December or January. Let me just real briefly. Yes.
Turn your mic on. We had 2 percentages. One was 0.25, and then did you say another?
0.4. Yeah, so the total would be about 0.6, and the reason why it's 0.6 is because the 0.4 is only available to the non-TPR hospitals. So it turns out to be about really 0.6. But 0.4, let me go back. Each of the last 2 years, the Commission has included infrastructure support. This is sort of like seed funding, if you will, in the rates of hospitals, so they can begin to bring on, you know, do the various things that are costly to do to improve care coordination, improve partnerships. They included 0.65 in the first 2 years. So now, in 1 year, in the fiscal 16, we're proposing, if the Commission approves, 0.4 goes to everybody except for the TPR hospitals because they got money up front. And this 0.25, about $40 million, would be set aside for competitive proposals. The Commission will be receiving reports. First of all, we'll be receiving a report on how the infrastructure money that has been provided in the past has been used, and that will be public. And then we'll also be asking, and we haven't detailed this yet, but we're asking for sort of a strategic plan from every hospital in the state. So all this will dovetail to about around December 1st, January period. So the reports for the planning grants will come in, the strategic plans for all hospitals will come in, and then we'll, you know, talk about this next 0.25 or the $40 million. Not going into any more detail, let me just summarize. I know this is difficult to see. I know I can't see it. The 8 hospitals or 8 partnerships that received grants are here on the slide. Let me get mine. The first 2, one was led. So on the right there, since this is in hospital rates, you have to have a lead hospital because we applied the money into the rates of those individual hospitals. But if you look into the proposals, there are a whole series of partners that include other hospitals, that include community partners as well. So,
Steve, would the competitive proposals also need to be led by a hospital, or can they be?
Yes, they would, because it would be placed in rates of that hospital. That's right. So the first one's a Johns Hopkins proposal, received $400,000. A University of Maryland proposal received $400,000. And by the way, both of those hospitals are on each other's, are collaborators on each other's. And we've asked these two hospitals, these two collaborations, these partnerships, to work together because their population, their targeted population is in essence pretty much the same. And their end goal is the same. They have two different models, and we'd like them to work together. So they're going to be bringing on some consulting resources to help them find synergies in the two different models. And we thought both of these models were very meritorious, and we hope that the result will be better care for the citizens of Baltimore City. As you can see, in Western Maryland, we divided the money among the three hospitals there in Western Maryland for Trivergent Health Alliance. Anne Arundel Medical Center is the lead on the Bay Area. They received $400,000. Nexus Montgomery, Holy Cross is the lead, received $300,000 because partially they're fairly well developed and on their way. The group felt that they didn't necessarily need the full amount. They've invested quite a bit already. Same with Howard County Regional Planning Grant. And then there's a collaboration with University of Maryland, Upper Chesapeake, and Cecil County, received $200,000. And then finally, Southern Maryland, we've provided $200,000, but it's on a slightly different track. We asked them to come back to us with a more robust proposal. This is one of the ones that they didn't really have good partnerships in the past, and we want to encourage what started there to be able to continue and have a pretty well-developed plan. So we're kind of starting from scratch with them, and hope that those partnerships will become ingrained and sustainable over time. And I'll leave it at that.
Are there any questions specific to what Steve's presented? So my understanding is that with all of these, one thought is that in fact these become model projects with concepts that can be potentially modeled in other parts of the state.
Exactly, yeah. So one of the criteria that the work group looked at was sustainability and scalability. So they didn't want to fund something that was a great idea but has no way of being able to scale beyond what they're proposing here. So yes, that's an important aspect of it.
Good question, Steve. I just wanted to be clear on the timing. Thank you for that. On the .25, the competitive grants for implementation, I thought I heard two different things. Is the application going to be in December or subsequent to the time that you're getting those?
Yes, it will probably be at sometime either late December or into January. We want to first to get the December reports in, and then provide a little time, for that. We haven't determined that yet. In fact, the recommendation hasn't been approved yet by the commission. But we'll put that together. I recognize your point that you need some time to be able to put a proposal together.
Thank you, Hillary. Yeah.
Thanks. I'm wondering, is it possible for us to find out sort of very big picture about what each of these groups is doing, or is that proprietary?
Yes, no, absolutely, and I would encourage it. On our website and on DHMH's website, we each have pages for this, and we've posted the summaries of each one of these projects by category. So you're welcome to go through there. And quite frankly, if you are an organization, a community organization in those communities that you have something to add, knock on their door, and say, listen, we'd like to be part of this planning process. It doesn't mean just because the contract says that you're limited to those partners. Other partners can certainly join on. So please take a look at them and feel free to contact them.
I think Tiffany sent out a link yesterday to that on the email.
Sorry, I missed it.
You can tag to it because I was reading it this morning, I think.
So in the subgroup meeting, one of the thoughts around this was that that we do have these projects which are now only in planning stage. How that is, I think, is absolutely critical. But there is an opportunity, as Hillary's question suggests, to look at those and the consumer engagement pieces of them and see how we might integrate some of those ideas or identify the needs and provide some potentially going forward recommendations. And I think because it's a planning process and they've got their first report is due in September, I don't think anybody was suggesting that we were going to go in and tell them what to do. But there are things, and I think to bring us back to where we actually started, what was with some core principles. And I think that we should, go back and relook at those as we sort of put all of this within context as well. But then what I'd like to do, unless there are any thoughts around that, what I thought we could do is go back and look at the planning chart that we started for the strategic plan. And in fact, Hillary built out on that, I think, in a constructive way, although we're supposed to say draft on this process, right? And so I think that we would find it constructive if we sort of took a look at this and talked through this as a potential way to move forward.
Lenny, before we get to that,
yes.
You said if we had any comment on this.
Yes, absolutely.
It might be that our group would recommend that in the competitive grant process that there ought to be points awarded for having someone with community consumer credentials in the steering committee of the grant, just to try and change a little bit of the emphasis, because I know we all get very comfortable with what we know, and your comment about the mental health individual really struck me as similar to myself trying to get help on my computer. Now I've had IT in the hospital report to me, and people would say I ought to be able to run my computer, but I ran into a problem with Google Share the other day, and I wound up having a fellow from India walk me through this. And the way I did it is I initially started with, you have to assume I know absolutely nothing about this product, and walk me through with me telling you what I'm looking at and you telling me what it means. And within a very short period of time, I got to my answer. And I realized that's the same kind of an approach that we need to be looking at. We can have programs that we understand to be very well integrated and comprehensive. But to the individual who's not familiar with even our language, they are not comprehensible, let alone well integrated and comprehensive. So it's a little bit of that, but by forcing the process to include more of the consumer voice, I think it might be building some basis even for having the hospitals have consumer voices in their governance structure.
Yeah, and also the health literacy piece that we were talking about earlier, making sure that that they are demonstrating that they have somebody with the the specific health literacy skills required. I think that's interesting. Thank you, Diane.
Right, and so the performance measurement role of mine makes me suggest that there's a way to also measure in some tangible way how that consumer engagement, that there's a measurement of that, and that you can report about that and potentially link it to what the positive results of the intervention is, interventions are themselves.
That Ms. Measurement here next to me, when we were discussing with the Anne Arundel Medical Center when they were presenting on their PFAC, and I afterwards said that was meaningful engagement. I think that that's an important concept too. And Diane's question was what made it meaningful. And for me, the best example was that the patient and family advisors were brought in during the process of preparing a document. The document wasn't handed to them once it was done. This once happened to me in my museum world when, they came to me with a really great-looking flyer and brochure, historical brochure, and said, "How do you like it?" And I opened it up, and there were two errors on the second page. And I said, if you brought it to us first, we might have got these, and you wouldn't have 100,000 run on them that you're going to have to throw away. So, I think, that's a great recommendation to have that. Thank you. Anything else? And then otherwise, we'll let Hillary kind of talk us through this idea. Okay. And I'm sorry to those on the phone that you don't have this, but it'll be a work in progress. So
it will be, and as those who have it can see, it has very rough draft stamped all over it. So, and I'll try and go through this fairly quickly. You all have it and can read through it, but I wanted to take the chart that we had been working through and that was a little bit stuck, and see if we could sort of flip it, and rather than having the chart, which was sort of a very tactical rollout plan, think at a bit of a higher level about, well, when we get to that rollout, what exactly will it be that we're pushing out? And so started with the core principles that we discussed in the very first two meetings. So the goals being to engage people who use or are potential users of hospital services as active participants in their own health care. And I think that is confirmed by the findings from the regional forums and what people are asking for in those. And then the sub-goal of that would be to engage people who use hospital services in health policy planning, service delivery, and evaluation. And that goes to the charge 2 piece. How can people's experiences get fed back into the system and funneled up to inform policies so that we can improve on, keep doing what we're doing well when we get positive feedback and correct what is not going so well. The objectives flow straight from those and, again, are adapted from the core principles, so I won't go over that again because you're all familiar with those. In terms of target audiences, this is significantly simplified from the older chart and just identifies those that we know about. And it's sort of very much thinking about the pyramid, right? You've got the high utilizers and their caregivers at the top, where there are a lot of costs. Then people who do use hospital services with some frequency, and then everybody else, because of course we're all potentially users of hospital services, so we're all potentially putting costs into the system, but want to focus where we know there's that interaction. I won't go into the strategies and tactics in detail now because they're currently all over the place, but wanted to just present some overall thoughts, which are my sort of compilation of the conversations that we've had over the last several weeks. One is to remember that there is no one-size-fits-all solution in terms of strategies and tactics. Different people are going to want and need information in different ways. And so we need to cast a pretty broad net in terms of that. And in doing that, we need to make sure that any and all materials provided can be customized to the specific region that they're going to be rolled out in, and that everything should be available in the full range of formats. There will be those who really only want to have that in-person conversation because that's the way they can absorb the most information and they want that relationship. There will be those who will say, you know what, I'm busy, I just want the info when I want it. Give me a website that's easy to navigate. Send me a text message when it's time to do something. So, recognizing that especially when we think about a family, for example, you may have the patient themselves who is really searching for a personal interaction, but they might have a caregiver who is, working full-time, caring for their older parent and has 3 young children and just wants it quick. So we need to meet all those needs. Skipping over to the back of the page is the messaging framework. And this is an inversion of the pyramid because the messages need to funnel from the general public and come down into those who are going to really need a lot more communication in terms of the high utilizers. So the messages for the general public, again, very much informed by the great feedback from the regional forums, are, highlighting that Maryland is doing something unique. This is, this is new. This is, we're breaking new ground here, and we can be a model for the rest of the country. That's pretty exciting. And this is all the type of information that can be pushed out pretty quickly because it's things that we know. Explaining to people that global budgets aren't going to impact their ability to get care. Making sure people know that their health information is protected. And very much using language of affordability rather than cost in all of this. This is something that Lynn Quincy was very clear about in her presentation, that while if we think about it from the systems perspective, we're thinking about the costs, but from a consumer's perspective, an individual really is not that worried about how expensive the healthcare system overall is, but they're worried about how much they have to put out in their copay, or how much their medications that might not be on their formulary are going to cost them. So explaining it in terms of how all of this impacts affordability for the patient, the client, the end user. Filtering down from that is the audiences who are actually interacting with the hospital system. And so a lot of this is those care coordination types of messages. You know who your primary care provider is. If not, this is how you can find out, or here's a resource to help you find out. Do you understand what you're supposed to do when you leave the hospital? Do you have someone who you can call for help with those things? So these are the sets of information that can really sort of be the first stepping stone in that pathway of care coordination, and begin that conversation. And then, of course, for the high utilizers, do you have a care plan and guiding them to those resources to create that, encouraging them to create that. So, as I say, that's very rough. Throw it out for feedback. I'll put it on Basecamp, send comments to start a conversation.
Yeah, I think this is great. Just two suggestions on the messaging framework, pulling from the focus groups we did with OpinionWorks. They said really, even mentioning global budgeting took you down a rabbit hole. I think you don't even need that bullet. I think you really address those points very well in your other points here. So I might suggest just striking the global budgets will not impact your ability to get care. And then on that the one right after that, I think we heard in those focus groups that they really liked that they had control over some of these decisions. So rather than just saying, we'll protect your healthcare information, you can say you can control who sees your healthcare information, so that your caregiver, whoever it is, because some people wanted people to talk, but they wanted to control who could talk to each other. They wanted that conversation to be going on, but so I think reframing that to you have control over your health information is a better, more actionable piece for consumers. But great job.
So I really love the term "no wrong door" that several people have mentioned, and I think if there's a utility or a strategy to put something like that at a statewide level into place, it would be it's probably a bigger strategy as opposed to a tactic. But how one does that, I don't know, but I think it's an incredibly important concept. And in particular, what Kim presented, so that there would be a place to turn for this individual that called you to say, well, gosh, this is going to be layers of things like an onion. You have a healthcare provider who is your psychiatrist. You have a counselor. You don't get along with he or she exactly or like them. You have a primary care provider, you have a managed care provider, you may be case managers bumping into each other. So open the door and figure out how one helps that person navigate through all of that. There's so much resource being thrown, but not connecting the dots, and that seems wrong.
So maybe we could come up with a new term, because the term "no wrong door" is taken in effect, and I would love to see us have a recommendation that in fact the state should create no wrong door, because right now the commitment isn't there with the IT to make that happen, right? So, but we need to create that in order to ensure that the new all-payer model, I would argue, is a success, because we've recognized that getting the social services is just as important. So no matter where somebody goes, they ought to be able to get both health and social services. But maybe there's and Donna said no wrong portal, which is a slight variation. So Ms. Communication over there is.
I 100% agree with the no wrong door concept, and I think that if we put it in the recommendations to create something like that, that's great. I would caution that we don't want to put out that kind of messaging until it's there and it works, because false promises are not a good way to go, and we wouldn't want to have people thinking, oh well, I can go to any of these places and I'll get what I need, and not deliver on that. So I think it's a long, long way to go before we can include that in messaging.
I would second that, because of the same thing that you were talking about. If Care First has assigned somebody to you, and the hospital has assigned somebody to manage your case, and one of these networks that we funded as a specialty project have all assigned a case manager to you because you are a high utilization person in a particular area, then the idea that you've talked to one of them doesn't necessarily get you to the right person to solve the problem that you're looking at. So it's kind of it is the central problem. There isn't a person to coordinate that information for you. And it might be one of the things that we think about in educating people about choosing their primary care professional. And the primary care professional may not be an internist or general medicine person if you have cancer. Your primary care professional might be your oncologist, who then coordinates all the functions of everybody else in that process. But it's a difficult process for anybody. And even when you understand a lot about the process, it's difficult to manage it when it's your dad or your in-laws or somebody who's going through it.
Yeah, and let me be clear, I was not suggesting that we put no wrong door in the messaging section. I was suggesting that we send the message to the commissioners in our report, that's an infrastructure piece that should be in place. Yeah, couldn't agree more about selling something that isn't there. So,
well, as long as, it's interpreted correctly. If there's going to be a campaign around this, one of the things that I'd be concerned about is that it could be interpreted by people, oh, it's still okay to go to the ED for all of your care. And that goes totally against, the ED is still open to you. Go there for all your primary care. And it's not the best thing for the patient. So, as long as it's true, yeah, that's exactly. If I can make another comment, I just wanted to kind of expound on what Suzanne said. And Suzanne's right. The focus groups did talk about not getting into global budgets. However, the rabbit hole that they got down into was the fact that they felt like it would be rationing care, which we all know in this room it's not. But what I thought what this bullet is trying to do is basically trying to debunk that, and help people understand. So maybe we don't use the term global budgets in here, but we say something like the new model, the new system, or whatever term that you think people would understand. But it will not impact the ability to get care. I think that the rest of it is very important, so that people don't, if they do hear about global budgets, because they do, and the first thing they think it's ration care, and it's absolutely not. So I think that's an important aspect. Maybe we just change global budgets to something else like the new all-payer model, the new structure, the new system, the new whatever, will not do that.
Can I offer a follow-up to that? And perhaps instead of keeping it as a negative statement, shift it to a positive statement, and kind of reflecting again what we're hearing from these the evaluations is increased collaboration among providers will help you get the care you need.
Access,
you know, like something like that.
Access.
Better access.
Yeah. Yeah, I think that's a good idea.
Yeah. Because I think it was partly the negative connotation
Sure.
too. Like
Suzanne, could you just say that line?
Yeah, increased collaboration among providers will enhance your ability to get care or make it easier for you to access care.
Great, thank you.
Yeah.
Any other thoughts? Kim, your hand is on the button.
Well, this would be a wish that they would, that the message would be, like, instead of do you have a care plan, and I don't know that this can exist, but do you know who to call? Because I think the hand-holding and the trusting relationship is going to be really important. Access to information we know is important, but if the person's really sick, information isn't, it's like they need a guide.
And do you mean for completing the care plan, or because we have, do you know who to call when you leave the hospital?
Do you know who to call before you go to the hospital?
Okay.
Would be that's what actually led me to think about this. Do you know who to call before you go to the hospital? Because I think people are in this mode of that's where I go, but they need to be prevented from first walking in the doors. So what do they do before they go there? And I think what Suzanne just offered, which is our language, we might want to talk about coordination. So better access to care because of better coordination, or something that's more lay term.
Right, I think Tiffany brought up that even may be a too sophisticated term, providers that work together.
Yeah, I've spent the last several weeks going every week with a Korean friend to her doctors to be the translator, and we've got the neurosurgeon, and then we've got the pain management guy, and they are not communicating with each other. And after just yesterday when we came back, she said, these doctors just have to talk to each other. And so that's bringing it down to, as you suggest, Diane.
But they have to talk to each other before we tell them that they're going to, because I think some of this is trust. So we say, this is going to happen because it happens on paper. But do we really know that that's what's happening when the person makes the phone call?
I found an interesting tool. I don't know if you saw it. I put up on Basecamp. It is a 1 or 2 questions that's been used with family practitioners and almost 100,000 people. And it asks if people have confidence that their care is managed, if they have confidence it's going in the right direction. There's some very simple questions. And a person having confidence means that they trust. And so I think we should consider a tool in measurement that provides us a way to look at how people are engaged, because it looks at both how they're engaged in their care and whether they understand what's going on with their care. So I don't know.
Yeah, and here are the two. I was going to thank you for mentioning that, because Diane sent around this health confidence article. And the one question is, how confident are you that you can control and manage most of your health problems? And then on the health information side, how understandable and useful is the information your doctors or nurses have given you about your health problems or concerns? So we might, yes.
So those are great questions. I'm wondering, it just popped into my mind, if I read that, but I don't really get it, I'm not going to give you the right answer, the honest answer. But I think we need to really just kind of keep in the forefront of our mind that we're going to have, hopefully, more stock in our community health workers that might be able to sit down and help that person talk through that in their culture, in their language.
Yeah, right. And that this is aimed at asking these questions when they're in the provider's office or with somebody that can talk them through, so that the provider, because that one of the things that Dr. Mathias said when we had our conversation was the central role that providers play. That come up multiple times, and I think that we need to, make sure all of that is in the mix as we're thinking about the messaging and the messengers.
So something that this conversation brings up for me, which isn't reflected here, but that I think is important, is to remember that the most important person on the care team is the patient. And when I hear a lot of the conversation we have, we're talking about coordination and communication, and this doctor is not talking to that doctor, is not talking to this caseworker, etc., and that's very important. But really the common factor between all those is the person at the center of it all. So making sure that these things are designed in a way that empowers patients to really say, I am the most important person in this. And that's a true culture shift because, you're the healthcare providers, you're the experts, and you know the system. So you guys figure it all out and tell me what to do. I work in this area, but when I access healthcare, that's the way I feel about it. So I know it's not the way I should, but so within that messaging, yes, doing the hand-holding that needs to be done, but being careful to do it in a way that still that we can still give the reins to the person who really needs to be in control of their health care. And sometimes it might not be the patient, it might be their caregiver or something like that. But.
And this isn't within probably, or maybe it is the realm of what we really work on, but that person-centeredness, when I do some trainings to assisted living staff or people who are care providers, and talk about the paradigm shift and that you need to really listen to what that person's saying, inevitably, all of them say, that takes too long. So I think what happens is you have people who work in busy offices who are doing what they need to do, and billing doesn't go along with listening to the older person who repeats themselves a couple times or starts back at 1920, And so just like that, we have to do that, but there's this barrier. I think that we have to acknowledge that the people who are doing that talking are also like, I got 15 other things that I need to do. Do I really have the time to do this? And they should, we know they should, but the realities are there's a lot of frustration.
Yep. Thank you. Any other immediate reactions to this? So then looking at the next steps, so the next subgroup meeting is next Friday. Is that right? Yes. And so we will be hearing Linda Al-Duri, and then I think shifting and building out from this. So any of you who aren't on the subgroup and who might take a look at this during the course of the week and send us your ideas, because we're sort of running out of time on our initial preparation for the report. And the next meeting for this group will be June 19th, at which point we will have the beginnings of a rough draft. Hopefully Tiffany's also shaking her head yes, because I'm looking at Diane. And then we'll meet again 2 weeks after that, because then that'll be the time to make any final changes before we get it into the commissioners for their early July meeting.
Did you say we have a rough draft?
Oh, great.
Our July meeting.
You're kidding.
Yeah, we.
All right. Serendipitous.
So that gives you a little more time for the August meeting, unless you wouldn't be ready for the June meeting.
And when is the August meeting? When I'm on
second
vacation.
Wednesday of August, whatever that is, the 10th or 8th or
great. Well, let's
something like that.
talk about that. Okay.
But this just happened yesterday.
Yeah. Okay. So we have an extra month, so we'll take that into consideration.
I think by drafting in an outline for the report.
Yeah, yeah. Yeah, no, we've got to have a concept paper pretty soon to start plugging some
So
of
we
this
have
in.
the key piece sections.
Yes, yeah.
Identified. Yeah.
Yes, Hillary can send it to Tiffany and.
Yeah. Or maybe I'll put it on Basecamp and everyone can edit the shared document.
Great. Thank you.
Or maybe not, because Gary's looking like, oh.
Again, my ignorance on the shared services.
I'll email it out.
Put it out there. I don't mind testing, but if I edit it and then you edit things, you edit.
Well, on Basecamp, you have to pull it off, make changes, save it, and then put it back up there.
Okay.
So it's not like a live. It's not like Google.
I'll email it.
If there were 4 people who wanted to change a word, I want to see what the 4 words would.
Sure.
There's a way where you have 2 documents edit.
Yeah.
Right. So instead of having the crash course in Word and merging documents and tracking changes, Hillary could just email it to me, and I'll send it out to everybody, and you can get your copies back to do it.
Okay, let me see if there's anybody on the phone that would like to comment during our public comment period. Is there anybody on the phone? No. I just want to be sure. Okay. And the one member of the public that's in the room can introduce herself. Part of the brain power. Any closing thoughts from anybody? Anything you're concerned about or want to make sure is on our radar screen? Okay, we'll look forward to hearing about the June 2nd forum and any other activities. You know where to find it. Thank you.